Oh, hey, Chris.
Hey Chuck, how are you?
I'm doing pretty well. It's a Thursday night. We both had busy days, but what better way to cap off the day?
Yeah, it's been a fun one. I just spent a little bit of time on firsthand, my side gig, other than this, and the day job. But I'm excited to spend some time chatting with you. I think we're gonna get into one of these technically heavy detail episodes that everybody seems to dig so much.
Oh, I am looking forward to it. And that's a lot to have to host two podcasts on the same night. Um, can you share who your guest was?
Yes, we had a great conversation with David Ring. I will say that having co-hosts for each of these things makes it incredibly much more enjoyable. So Megan Conti-Mika and Peter Stern, obviously for firsthand, and some guy named Chuck for the old podcast.
That is awesome. I have to say, I had a side gig podcast last night, which is pretty interesting, honestly. I have a co-host, Alexander Aleem, and this is for the AOA, I think you know. And
Mhm.
we interviewed Jim Herndon, who is a giant in hand surgery. Oh, no, I'm sorry, a giant in orthopedic surgery. He has a ginormous 5-volume book coming out called A Birth of a Specialty, I think that's what it's called, about orthopedics in Boston at Harvard Medical School and the various hospitals. It sounds fascinating. It sounds dense, but he was just sharing some stories and anecdotes. It's pretty cool, pretty fun.
Talk about a labor of love, both your other podcasts as well as Jim Herndon's book. It's interesting. We were just reading David Ring's New England Journal article about a wrong site surgery, and it was in the format of the M&M from the Massachusetts General Hospital, in which Jim Herndon contributed his thoughts. So, perfect timing on that.
Yeah, really interesting. It was a 14-year project for Dr. Herndon.
Wow.
Yes,
Wow.
that is more years than your children have combined, I believe.
Yeah. I mean, my math, if my arithmetic serves me correctly, they've Dr. Herndon's been working on it for 5 more years than the kids have been in existence combined. So, yeah, well, I look forward to checking that out. How often are you guys doing the AOA podcast?
It's about once a month on average. It's probably not 12 months a year, maybe 10 months a year. What about you?
We do once a month for firsthand. We've slowed down recently. We're taking January off, and we had a little hiatus just to make everybody miss us a little bit. And we'll talk about that for our podcast in a little bit.
Yeah, well, you and I have discussed we might need a little hiatus ourselves.
All good. So let's jump into this episode. Everybody loves the technical aspects here. So I want to present a case to you. So I've got a 25-year-old gentleman who comes in 6 weeks out from an injury in which he was using a drill, and the drill bit broke and it kind of torqued his wrist a little bit. And he is, like I said, 6 weeks out. He's got pain on the ulnar side of his wrist. And you have evaluated him and you've determined there not frank instability, but there's enough instability where it causes him pain. In addition to having localized tenderness over the ulnar fovea, you have sent him for imaging and you have obtained an MRI with or without an arthrogram that shows a TFCC tear. And I will let you fill me in on the details of what you would like that MRI to show specifically and how it would change your management.
Yeah, and we could, we haven't done a lot of imaging discussions. We can and should. The problem, of course, with imaging is that, like politics, it's all local and it depends on quality of your magnet, quality of your radiology partners, et cetera. I will occasionally use an arthrogram. I have to say, many times I do not use an arthrogram. It depends a little bit on where the patient may be getting the test done. I have many patients come back and say the arthrogram was one of the most uncomfortable interventions ever because of the placement of the needle in the wrist joint. So I actually try to avoid it if I can. But I'm really, with the description that you provided, um, you can get a peripheral tear and have pain only. When you start to have even a suggestion of some laxity, and by laxity, we're talking piano key testing or shuck of the DRUJ, then I worry there's really a bigger type tear, a structural tear that may affect the fovea. Those can be hard to pick up on MRI. So I think it's a combination of exam and discussion with the patient, and the MRI contributes.
So before we get into the specifics of how you tease out the differences and those tears and the implications, so if I'm starting out in practice and like you said, all imaging is local, should I just call a radiologist and ask, what's going to give me a better picture at the place that I'm having most of my imaging done? I mean, because I think we've talked about this before on this podcast or one of our other venues, maybe it was conference or a hand conference, but I remember starting out in practice and you saying, I always get an arthrogram. Why would you do anything else? Duh.
It's funny
Maybe not with
because
the duh at the end, but
maybe with the duh.
Yeah.
I was actually thinking as I was talking that you and I have discussed this, but I don't remember where
Yeah.
either.
Multiple venues.
Yeah. So I do think that's probably good advice. And many radiologists will recommend the arthrogram. It probably does give a little additional information. It's a cost benefit analysis. And I'm not even talking physical cost. I'm talking kind of the implications of the needle placement, of getting the arthrogram injection, et cetera. I would say most of us would agree that it would increase the sensitivity and likely the specificity for identification of a Tfcc tear. How much? Again, very local. So I would talk to your radiologist, get a sense of what's going on, and then once you do a handful, and you'll get a sense of whether it is helpful or not.
In 2021, with your skills of being a hand surgeon for at least 50 years, do you feel like the arthrogram extravasation down the sigmoid notch, the so-called J sign, does that help you establish any prognosticators about tear, or are you getting all that info on your examination since you've been examining patients for about 60, 70 years now?
Yeah, 80, 90 years.
It just keeps going up.
I don't think the arthrogram really helps me. I think I can get a sense of what's going on by clinical exam. MRI definitely adds information. Like I said, fewer and fewer reasons for me to get the arthrogram moving forward.
I mean, it's interesting. I know we're here to talk about like surgical details, but I noticed that the stuff that I'm super comfortable with at this point in my career, I guess 6.5 years into practice now, I order less studies for that stuff. But the stuff where I'm still populating my algorithm on clinical exam and how patients look and how patients are going to do, I still get studies. And I would say I probably get more studies now because I'm still trying to hone what I see on my exam, what I see in the OR versus what I see on their imaging, because I've become more interested to see how good I am at predicting that now.
It's such an interesting point, and it is so true. And certainly when you get old, like one of us, you don't want to stop being inquisitive and stop trying to improve that correlation assessment of imaging. But I do order less tests than I used to. And I think I do that from a place of knowledge. I'm not critical of those who order tests. And certainly there's value in tests, but I do think my indications have narrowed for sure.
So say you've got this patient and say they've got, quote, just a peripheral tear, but they've still got that subtle instability on your exam. How are you getting, what are your options here for treatment? Are you going to, try some therapy, maybe a wrist widget? You're going to do an injection, or are we going to the OR?
So it's interesting, the 6-week time frame which you described. So twisting, drill, injury 6 weeks ago. That's quick, honestly. Most people don't come in that soon. If they did, I would really strongly consider a cast. The problem, of course, with recommending a cast is A, it needs to be a long arm or a Munster. And B, I can't give good data and I can't promise it'll work. And then you put someone in a cast for 6 weeks and you may not have anything to show for it. But I do think that's reasonable in the acute or subacute setting. Once this is at 3 months or 6 months, I really do like a single injection with a wrist splint, anti-inflammatories, activity modifications. I do not believe in repetitive wrist injections, but a single injection gives me a lot. Number one, it hopefully helps the patient. Maybe not forever, but helps the patient. Number two, it is a diagnostic test, let's be honest. And it also helps me and the patient understand that if the injection works and wears off, then surgery really feels much more comfortable rather than just jumping to surgery. I don't know. Does that resonate or do you see it differently?
Yeah, no, it resonates with me. I mean, I try not to jump into surgery quickly. And, I think that, the injection is totally reasonable. I like a wrist widget, as many of our therapy colleagues have pointed out in the past. I guess for me, say we fast forward to 3 months, some relief from the injection, still has that instability. absolutely want something done. They come to the master, the professor, the executive vice chair, Chuck Goldfarb, and they need to know, what are you going to do to me? What can you do to help me?
Well, let me first say that of all the therapy tricks and tools, the wrist widget is one of my favorite. It is a fantastic option for all things ulnar-sided wrist pain. It can be TFCC, it can be ECU, it can be vague wrist pain. There's a chance the wrist widget cures it. So I love that suggestion. Sometimes the therapists custom make them. You can order it on Amazon. There's a variety of different types. It's a great tool.
Well, I love the wrist widget mainly because I see a lot of vague ulnar-sided wrist pain in my practice, and maybe it's because I'm seeing certain diagnoses and they're seeing me and I'm not seeing them, but it works. It works. It's a great first step, and patients seem to like it, and obviously our therapy colleagues provide a great resource with that.
So let me envision the Christie ulnar-sided wrist pain exam. Starts with a cubital tunnel careful examination to make sure that nerve is stable. And then a distal ulnar tunnel, a Tunnels and a compression test. And then we don't want to forget the sensory branch of the ulnar nerve.
Exactly. The nerve of Calfee, as our partner Ryan Calfee described in his award-winning article. Yeah. So I mean, you always got to start with the thing that's the most important.
So
then there are apparently bones and tendons and stuff underneath.
Irrelevant. All right. So in all seriousness, if this patient comes to surgery, and for me that, there are a lot of variables, but a younger patient who had a great response to an injection that wore off, whether that be 3 months or 6 months, I really feel is a good indication for surgery. The reason I think it's a good indication is number one, an arthroscopic intervention done well is safe, minimal morbidity, can be done, in a relatively short fashion. And I just have good results. So I like it. And I don't think everyone would agree with everything I just said, but I like the procedure. So for me, it's a wrist arthroscopy. As I think I've said on this show before, I don't love diagnostic wrist arthroscopies. I like to have an idea of what I'm going to do. I don't almost ever do a wrist arthroscopy to just see what's going on. That doesn't feel right to me, although again, I recognize that for some, it can be a true diagnostic tool. But in the scenario we've provided, yes, you're going to confirm what's going on with the TFCC and with the ulnar-sided wrist pain, but I kind of have a sense of what might be going on before the case.
It's interesting, when we did the last firsthand in November with Jeff Greenberg from the Indiana Hand Center, it made me feel like I ordered way too many MRIs, because I like to really have a good sense of what's going on before I hit the OR. But his feeling was that I presume he's ordering less MRIs, and he's using the scope to confirm his clinical diagnosis, which again, after many years, has been honed to the point where maybe he doesn't need an MRI. So I think, there are a lot of ways to do it. I fall more into your camp than his, but maybe one day I'll get there.
Yeah, I think I'm heading in that direction, but I'm not there yet. And there's there's so many variables, whether it's work comp or not, and getting approval and the like. So maybe I'll just talk through the scope process, how I see it, how I do it.
Why don't I give you a lightning round, and you can answer some of these questions? How about that?
Thank you. Making it easy for the old guy.
All right, perfect. So in the OR, normal hand table?
Normal hand table with a leg.
Okay, hand table with the leg. Why the leg?
You don't want the hand table kind of wobbling up and down without the stability. So just like you would insist on a leg to that hand table for a scope case, I insist
the cool kind of scope, the microscope.
Yeah, the other kind of scope.
As a rule for our residents and fellows, if there's word scope involved, put a leg on the table.
There we go. We just simplified it.
There you go. So I feel like this is a consensus agreement of 2021. So, okay, tourniquet?
Yes.
Okay, and then we've talked about the LinvaMed traction tower in the past, and shout out to the reps who have contacted us to trial their new tower. I've tried it once or twice, and it's fantastic. But you can sponsor the podcast, email us. And if you're using the old tower that everybody had from the 1990s that had the VHS tape on it, what do you do in terms of setting that up? Because the VHS tape video says that you're supposed to strap that down to the table.
Yeah, so I still do use the LinvaTech traction tower. I do not strap it to the table. There's two straps I use. One to hold the forearm to the vertical portion of the traction tower, the other to hold the arm to the base of the traction tower. So that allows you to apply traction to the fingers safely. I use towels to protect the skin, and I use 10 to 12 pounds of traction, almost always to the middle and ring finger alone.
What is preventing the traction that you're applying through the finger traps from pulling the patient off the table?
It's only 10 to 12 pounds of traction. And I think as long as you hold the arm down to the tower, the setup is more than 10 or 12 pounds. So I've never pulled the patient off the table.
So as a non-expert in wrist arthroscopy, I set it up a little differently. I follow the old video, and the old video, which is amazing, has a picture of somebody with a tourniquet on and then a strap over the tourniquet, which I will do because I don't like stuff moving around when I'm trying to do my wrist scope.
No, I'm only got love for you. That is the old school way of doing it.
Okay, so we've got the wrist and traction. You said 10 to 12 pounds. Finger traps on which fingers?
Just middle and ring. That's it.
Okay. Does it ever vary based on where you're trying to get to?
Yeah, I guess if it's more radial-sided pathology, I might go index and middle. I never use all four. I don't think it's necessary. So it's 2 fingers, not more than 12 pounds. Been happy with the 2 central digits.
I've been told never to commit the sin of drawing your landmarks on a patient until you're in traction. Is that correct?
Absolutely.
What do you draw?
It depends on who's with me. I draw a transverse, almost always, 3-4 portal, and I draw where I expect the 6R portal to be, although I always confirm that with needle localization prior to making that incision.
Why transverse for 3-4?
It looks much better post-op. I don't think it matters. It doesn't matter a darn bit for access. It heals better. It's in Langer's lines. It looks better.
And then in terms of getting to your mid-carpal joint down the line, and we'll talk about that in a second, do you go through the same incision that you've made for 3-4?
Same incision. I take a curved hemostat, small curved hemostat, and I go a little more ulnar and a little more distally, such that I'm in line with the third metacarpal, about 1 centimeter distal to my 3-4 joint entry spot.
Insufflate the joint?
No, it doesn't help. I was taught to do it that way. It doesn't change a darn thing. It doesn't make it easier. You can't put fluid in there that'll separate the bones. You're not increasing the joint to nerve or joint to artery distance. Totally unnecessary.
I like it because it helps me or the trainee who's establishing the portals understand exactly where we need to go. I recognize that putting in a wrist arthroscope into 3-4 is kind of like tying your shoes for you. But for the rest of us, we like to have a little guidance.
Oh my God, it's totally unnecessary. Again, no problem. I mean, unless you're a dry scoper like some of our friends are, but no problem at all. I just don't think it helps me.
Okay, so take me through exactly how how you're establishing the portal, like every nitty gritty detail.
Skin incision transverse through the dermis and epidermis only. Blunt dissection down to the dorsal distal rim or the distal dorsal rim of the radius, and then using the curvature of the hemostat, I pop over and into the joint. I spread reasonably aggressive. You don't want your portal being huge because then the scope will just slide in and out, and that's not stable. But you also don't want to struggle every time you choose to pull your scope out.
For the former Gelverman trainees, is this a Gelverman like a person spread, or is this where is it on that spectrum?
Yeah, if a 10 is like your biggest spread ever, this is a 7.
Okay, got it.
Yeah, it's a good but not great one. And then I proceed with assuming I can see and there's not too many air bubbles or just things that are irritants, I start with my diagnostic arthroscopy, which I do the same way every time, which I can talk through if it's helpful.
Yeah, let's do it. So same way every time.
Yep. So you're looking right at the membranous portion of the SL ligament and the ligament of testu volarly. When you look radially, you're looking at the scaphoid facet of the distal radius and the proximal and a little bit of the proximal waist of the scaphoid. You can see a little bit of the styloid. And then most importantly, I like to confirm the radioscaphocapitate and long radiolunate ligaments. So from volar radial heading centrally. Short radiolunate ligament, also visible essentially straight ahead. I always pull the scope back drop my hand so I'm looking up. So I'm seeing the dorsal SL, which is perhaps the most important ligament on the radial side. If all that looks good, I move ulnarly. And then I'm looking at the proximal aspect of the lunate. I'm looking at the lunate facet of the distal radius, and I'm heading over towards the gold, which is the ulnar wrist and the TFCC.
Is there anything you're doing on the radial side before you establish a portal on the ulnar side?
Other than just making, assuming we're dealing with ulnar side wrist pain, no, I'm just taking a look to make sure I'm not missing anything. If I do see significant synovitis or something like that, I want to know why, because that's pretty uncommon. But otherwise, I just move to establish my 6R portal with needle localization, incision, blunt dissection, placement of my shaver in the joint.
Okay, so you've got your shaver in the joint now. Do you, let's say you are a wet arthroscopist, so no dry arthroscopy because you don't want to burn and blaze anything that doesn't need to be handled as such. When you're looking at this, are you using your shaver to assess things like the TFCC, or are you using a probe?
I think you can do either. I've actually been using a probe more. It really does give you a better sense of stability. So when I look at the TFCC, I start with a trampoline sign. And this is one of those tests where you need to establish your own personal parameters of what's normal, what's not normal. Really, the TFCC should be like a military-made bed, really taut and tense without laxity. If there is laxity, it doesn't
like a
mean...
trainee on their first day of the Goldfarb rotation.
The laid back Goldfarb rotation.
Oh yeah, sure. Maybe the Goldfarb rotation of 7 years ago.
So if you have laxity when you do the trampoline test, so you're bouncing your instrument on the TFCC, you don't necessarily know what's going on, but you know something's not right. And that could be a central tear, that could be a peripheral tear, that could be a subsurface or foveal tear, but you know something's not right. So I do that. There will always...
Your trampoline test, is there anything, is there any sort of internal control? Is there any other tissue in there that you can push on to give you a good sense?
No, I really don't think there is. So it is, and there's age-related degradation, I would say, and there's different changes over time, but no.
Okay. All right. So then what else do you use to assess?
Well, there's always synovitis on the ulnar side of the wrist, and especially in the pre-styloid recess. The pre-styloid recess is essentially due ulnar. There's always synovitis there because I think that's what's contributing to your pain. The synovitis develops because of pathology, and the synovitis is what I believe is causing the pain, and the synovitis is what I believe the corticosteroid injection takes away. And then by the time you're back in the OR, it's back, so you debride it. And then you're really looking for what's going on. And so you can look volarly, and what you're looking for volarly is a good understanding of the ulnotracheal and ulnolunate ligaments. And if you're one who believes the Mayo experience, there can be a split tear between those two ligaments. I don't see that often, but I trust the people who report it. Sanj Kakar believes strongly that that's a commonly missed diagnosis, so I always look for it. And you're using your probe, you're using your kind of historical context to see if there's pathology, inflammation, volar and ulnar. We're looking dorsal and ulnar right under the ECU tendon. So it's pretty uncommon to have a straight ulnar tear. Most of the tears are really dorsal and ulnar, and you're looking for a separation between the TFCC and the dorsal capsule. And sometimes that can scar in. And so the tissue may not look completely normal. You may put your shaver in that area. It's really hard to injure the TFCC with the shaver. And so I'm okay trying to clean that area up and see if there's a tear. Central tears or radial sided tears are usually obvious, but you need to make sure you don't miss one. And if there is a tear in either of those locations, presumably the dorsal part of the TFCC and the volar part of the TFCC are okay. So you debride those with a shaver, with a biter, and you want to just try to stabilize them so that there's less kind of wiggliness or rubbing, because I do think that can contribute to pain. You don't stitch a central tear because there's no blood supply, it won't heal. Radial sided tears, almost no one repairs them because there's no need to, and it's actually pretty tricky to do so.
That's the longest and most passionately you've ever talked on the podcast in the almost 2 years that we've been doing this.
I'm just getting started.
So how do you assess? You published on this, the hook test. Like, tell me how that plays into your algorithm here, and well, describe it first.
Yeah, so I'll describe it, then I'll give you my 2 cents. So trying to understand whether or not there's a subsurface tear of the TFCC is tricky. Some would advocate a DRUJ arthroscopy. I think that's really hard to do and visualize well. Some would advocate a straight ulnar, like a 6U portal, which has its own risk of nerve pathology or nerve injury. But I think a hook test is really great. So the hook test is basically your probe goes in the 6R portal, and you're trying to get a hook underneath the ulnar side of the TFCC. And if there is not a foveal attachment, you can lift the TFCC up. And again, it's a test based on your experience, but you can, make that diagnosis. The suction test is also an interesting one. It's not always positive, even if there is likely a foveal tear. But if you put the shaver in and turn on the suction and the whole TFCC rises, then there's nothing keeping it down to the ulna. And that's a clear positive sign of a foveal tear.
Well, before I get to my next question, let me ask you, how when you're doing your normal scope, how much suction do you have on? Do you ever have suction on? I mean, is it just a small bit, the full suction the whole time?
So I turn suction on whenever I shave, and I use the suction as full. I turn it on maximum, and I use it to bring the tissue that needs to be debrided to the shaver. And then I use it for this, and otherwise I don't use it.
So what's the importance of a subsurface foveal tear?
I'll start by saying the first 10 years of my practice, I wasn't aware, and I would say most or all of us weren't aware that that was a real entity, except for in massive traumas and things like that. And if you can't see it, we didn't fix it. So I was never taught to fix it. I don't know how many foveal tears I may have missed. I gradually became aware and learned to recognize these tears over the last 10 years or 8 years or something like that. What's remarkable, and here's the most controversial thing I'm going to say, is that I do a lot of scopes. At least I think my volume is high. I probably, on average, do 2 wrist scopes a week for ulnar-sided wrist pain. And I've actually looked at the numbers recently, so that's about right. Sometimes more, but I would say 2 is a safe number. When I do a TFCC repair, 75% of them are now foveal repairs, maybe higher, versus peripheral repairs. That's remarkable. And certainly I may have a little bit of a lower threshold for performing that kind of repair if I get a weird trampoline sign, if I get a positive hook test, if I have a positive suction test, if I have preoperative suggestion of instability. But it's real. I do not think I'm overcalling it. And I'll keep going on my passionate diatribe. Marty Boyer and I used to have these discussions in our anatomy session, because it used to be that we only did an outside in repair, and that would be a small incision near the ECU. You use the ECU subsheath as the stabilizing post, and you put a stitch through the TFCC. Classic, still very appropriate when it's called for. Jeff Yao started talking about using suture anchors or even meniscus repair kits that deploy a little device to repair the TFCC. But unless you're using an anchor and down to bone, or unless you are bringing the TFCC down to bone, the other TFCC repairs do not provide stability. They might help pain, but they don't help stability. And so this foveal repair is a stabilizer. It does make a fundamental difference to the stability of the DRUJ.
So what types of tears, either characteristics of the tear itself or stability-wise, what are the tears or injuries that aren't addressable with the foveal repair before we get into your technique on the foveal repair?
A straightforward central or a central TFCC tear, perhaps related to ulnar carpal impaction. Okay. A peripheral tear, I don't think it would be wrong to treat a peripheral tear with a foveal repair, but I don't think you need to do it. I think you can just debride it or do a outside in repair.
Do you see peripheral tears with instability, or are they typically foveal tears that have instability?
It's foveal tears that have instability. And it's rare, I don't want to misrepresent this, it's rare that you do a DRUJ shuck and and it is moving all over the place. And even if you do a good piano key where the patient puts both hands down on the table and you tell them to push into the table, it's rare that you see a big difference between the ulna mobilizing on one side versus the other. But it's just a sense, and the patient will tell you. If you ask them and listen, the patient will tell you.
So tell me about how you do your foveal repair in 2021.
Yeah, so there are different techniques, and I have really mainly used one technique. Sometimes you can freehand it, being very careful to protect that sensory branch, the ulnar nerve. And when I freehand it, I make an incision, an extended 6U incision, protect the sensory nerve, and then you can place a needle dorsal and volar to the styloid and bring those up and under the TFCC and put a horizontal mattress suture and tie it over the ulnar side of the ulna. But what I almost always do is what most people call an ulnar tunnel approach. So you make an incision just proximal to the styloid, work volar to the ECU, down to bone. You place a K-wire through the bone at a not a horizontal angle and not a very vertical angle, and you drill to the fovea. It's where the fovea is essentially where the styloid meets the flat part of the distal ulna. And so your goal is to exit the K-wire right at that point. The shorter the tunnel, the more ability you have to place a wide horizontal mattress suture. The longer and steeper the tunnel, it's very hard to separate your sutures. And so you can't.
The more vertical the tunnel?
The more vertical the tunnel. So I shoot for a short oblique tunnel rather than a very vertical tunnel.
Do you ever use the aiming arms that are supplied for that?
I don't find those helpful anymore. I think they can be. There's nothing wrong with them at all, but I don't use them now.
Okay. So then you've drilled this tunnel with K-wire. And how are you?
I'm sorry. So I placed the K-wire, confirm it by C-arm radiograph, over drill it with about a 3 millimeter drill bit, and then essentially the set I use is the Arthrex set. I don't work with Arthrex, and essentially you put the suture through the TFCC, you pull it out your 6R portal, and then you put essentially a loop through the TFCC in a horizontal mattress type fashion, pull the loop out of the 6R portal, then you put your suture through the loop and pull it all down through your tunnel, and you've got a great horizontal mattress suture.
So you talked about having a wide mattress. How wide is the right width?
Well, you don't want it to pull through, and sometimes the TFCC can get less substantial over time, but it's usually a pretty sturdy structure. I hope that it's at least 2 to 3 millimeters wide, the mattress, and usually it's just one mattress. I have done 2 mattresses on occasion for strength purposes or for kind of size of tear or size of patient, but usually it's one strong suture. It's fiber wire because it's Arthrex, and then you can do whatever you want to anchor the suture. I usually just use a little anchor into the bone.
What's the caliber of that suture? Is it a 2.0?
It's a 2.0. Yeah.
Yeah. And then when you're anchoring it down, do you have any pearls for tensioning or how you position the forearm, the wrist as you're doing it? Do you keep it on traction the whole time? What are your pearls for that?
Yeah, great question. If you put this suture eccentrically, I always worry that I'll lose rotation. And my suture it's not always perfectly in the middle of the distal ulna, but I haven't lost rotation. So that's point 1. Point 2 is I always tension it with no finger traction. So I'm sitting there at 10 to 12 pounds of traction. I release that. I apply maximum traction on the suture as I put the anchor into the bone. And as I put the anchor into the bone, I release my hold on the suture and just push it into the bone. And it's been pretty good. I haven't over tightened. I haven't lost rotation, and it seems to do the job. And the idea is that you're kind of irritating the distal ulna with that drill hole. Sometimes I'll put a shaver down on the distal aspect of the ulna before I put my suture to quote unquote roughen it up. But you're hoping that the TFCC adheres back down the bone, which provides stability and heals.
So for that technique, you described using that ulnar tunnel. When would you use that outside in? I think you described it as being a peripheral, not foveal tear, that you're obviously doing more than debriding. Is that an accurate assumption or
That's
summary?
that's exactly right. That's exactly
And
right.
then in terms of exactly how you would do that, you gave a little bit of a description earlier. For somebody who's learning how to do it, how would you do it?
Yeah. So I use my 6R portal. So I always make that portal longitudinally in case I need to extend it. I extend my 6R portal. I look out for that transverse branch of the sensory ulnar nerve. It's uncommonly present, but I look out for it. I dissect down to the ECU subsheath at the joint level. I open the ECU sheath and subsheath and put a Ragnell retractor, the small end of a Ragnell, to pull the ECU more ulnarly. And then I use a Meniscus Mender. It's called the Meniscus Mender 2. It's a Wright Medical first generation meniscus repair set, but it has perfectly small sized needles. They're curved. It's inexpensive. And essentially I put those through the ECU subsheath and into the TFCC. And again, I create a horizontal mattress suture. I pull it down to the ECU subsheath and tie it.
Is that device, that I'm saying this in all seriousness, is that device still widely available?
It is. It absolutely is. I think it's only used, to my knowledge, for the wrist, but who knows?
Okay, good. And then are there any other repair techniques that we should talk about open? I mean, is there still a role for an open TFCC repair? I know that's how some people only do it.
Yeah, I would say two things. First, there is, you can do a straight ulnar repair with TUI needles. TUI needles are cool. They're in the anesthesia set if you ever need one. Anesthesia always has them, and I think they may be in their lumbar puncture set. But if you ask the right person from the anesthesia supply team, they'll find you TUI needles, and they are essentially not sharp, and so they won't cut your suture. So if you visualize from the 6R, you can put your suture in from the 3-4 portal, and you can basically create a horizontal mattress and tie it over the ulnar capsule. So you basically take it and you put it through the TFCC from dorsal to volar and radial to ulnar, and then you have a little incision so you protect that sensory nerve, and then you can hold the suture outside the capsule, pull the needle back, and then push the needle through again, because the needle won't cut the suture. And then all of a sudden you have a nice horizontal mattress, which you can tie over the capsule. I don't do that repair very often because, one, true ulnar sided tears are not that common in my experience. And two, you don't want to close down that prestyloid recess, because if you do that, you will lose rotation. And then your last question is, yeah, ulnar sided open TFCC repairs are absolutely appropriate. And there are really good arthroscopists and good surgeons who choose that technique. I will sometimes do it. I find it difficult to put the sutures exactly where I want them. You can put an anchor in, or you can put drill holes through the ulnar styloid, but it is absolutely appropriate. It's dealer's choice, and I like it.
When was the last time you did one?
I have done one recently. It was a situation where it was a bad distal radius fracture without an ulnar styloid fracture. I fixed the radius. There was still gross instability, so I made an incision, and there was a massive foveal tear of the TFCC. So I put one anchor in. I wondered after the fact, should I have done two, and I did an open repair, and it was fine. It was fine.
Where did you put the anchor?
In this case, I put the anchor kind of dorsally near the styloid. So
Okay.
my incision was, there's different ways to do it. You can make a straight ulnar incision, or you can make essentially a transverse incision under the ECU tendon. And in this case, I was more dorsal. So I put my anchor there, and then I did a grasping suture of the TFCC.
So for you, what would you advise people who are learning how to do this technique? And because I noticed that in my training, I mainly saw you use the ulnar tunnel technique. I never saw you use a meniscus mender. I never saw you use a TUI needle, and I certainly didn't see an open repair. But one of the limitations of growing up in this era of newer techniques is that you don't learn the old school way of doing it.
There used to be a great course put on by Anna and the Hand Society for wrist and elbow arthroscopy. And it was a shame that course is not offered, because a lot of this is just being at a course, and I really think it's true, a course that focuses on repair techniques and arthroscopic techniques. And having a good senior partner helps, doing the right fellowship helps. But I don't know the answer to your question. I mean, you have to get exposure somehow. And I really think the problem with arthroscopic education is you have to see enough to be comfortable with pathology, because I still think our definitions of what is pathological are not completely clear, at least for me.
Well, on top of that, there's the variability in who's rating them, which I know is the topic of one of our fellows' research projects. So,
Absolutely, we're working hard on that one.
so is the post-op protocol the same for all of the different techniques you described?
Actually, for me, and there is no science here, for me, it is not. I use a short arm splint and cast for a peripheral repair. I just don't think there's much of a risk of that tearing out. So I keep life simple for the patient. For a foveal repair, I use a sugar tong splint for 2 weeks and a Munster cast for 4 weeks before I start therapy.
Wait, hold on. So for the tear that which you do not have a bone tunnel, you are less restrictive. But for the repair in which you have a bone tunnel backed up by a suture anchor, you are more restrictive.
I just don't think the torque is with rotation is much on that peripheral repair. And I worry more, because it's more significant for the foveal repair, and I would hate for it to fail. I just worry more about it. And again, may be nonsensical. I hope a listener will call me out and educate me if they disagree.
Well, it's clearly worked. So
it has worked.
Yeah, exactly. And when do you start, for our therapy colleagues listening? So say your peripheral repair, what's your protocol in terms of initiating motion? When do you get them out of that short arm splint cast orthosis?
Yeah, so it's 6 weeks. There's actually, if you want to be really precise, 5 weeks and 5 days later, start therapy in both groups. Volar resting splint, active and progressive passive motion. Once passive motion is restored, strengthening can begin. That's usually at 8 weeks. Strengthening between 8 and 12 weeks, and depending on how the patient's doing, ramp up thereafter.
So the rehab protocols don't change, just the initial immobilization between the two groups?
Yes.
Okay. And at what point do you sprinkle the holy water on the patient?
Every visit. I have a big vat. I need it.
Fantastic. Well, if listeners have any other questions about protocols and details for arthroscopy and TFCC repair, send it to us. I'm not even going to pretend to try to answer any of them, but we'll ask Chuck. We'll just change the name of the podcast to Ask Chuck. So handpodcast@gmail.com. Ask Chuck your arthroscopy questions.
Yeah, and I hope all you sports lovers out there, which we know is the majority of the listeners, I hope you guys are all happy and satiated. And look, I'm still learning, so educate me if you see things differently, please.
Fantastic. Well, we'll see you next week.
Thank you.